In this time of medical crisis, it's hardly an academic question. And it's something Sunday Morning senior contributor Ted Koppel has been pondering.
These are dark times, escalating demands, diminishing resources. To get a sense of where we may be headed, we have only to look at Italy. Theirs is one of the oldest populations in the world, which partially explains a death rate that is now close to 10%. In the north, Lombardy, the medical system is all but overwhelmed. Too few hospital beds, not enough gowns, masks, a desperate shortage of ventilators. You've seen what's happened and what continues to happen in Italy right now.
Yeah.
Dr. Maria Raven is Chief of Emergency Medicine at the University of California, San Francisco Hospital. You've got me on one gurney, and you've got a 25-year-old on another gurney. You've only got one ventilator for the two of us. Who gets the ventilator?
That's a very tough question. I mean, I think the answer that we would use if we were to follow principles from a specialty like transplant is that people that have more life years might get the ventilator. But there are also many other sort of principles that could underlie the decision making. You know, you have to take into consideration underlying illnesses that people might have, and you also have to take into consideration if there are other temporizing measures that you could use in one person, so that maybe you, after all, you wouldn't have to need a ventilator immediately.
Maria, you're tap dancing.
All right. I mean, this is a tough question. I mean, I don't want to necessarily speak for UCSF on this because they haven't put out their guidelines yet.
Well,
I mean, I think,
I'm sorry to interrupt you. When are they planning to put out the guidelines? What are they waiting for?
Well, they're any day. Actually, the clinical working group is working on them right now.
These are terrible decisions to leave in the hands of doctors on the front lines, the ones actually treating patients.
Well, there are certain situations, relatively few, thank goodness, that are catastrophic events that entirely overwhelm our ability to do what's right. Haiti was one of those.
Dr. Thomas Kirsch is an emergency physician sounding the alarm. He's afraid that what he confronted in Haiti in the aftermath of that country's earthquake a decade ago, desperate shortages of medical supplies, equipment, personnel, could soon face us here.
And that was the same thing I'd faced when I was in Haiti. It's about the most difficult decision that you can make.
You're still choking up all these years later. Why?
Good question. You think after 10 years I'd be beyond that, but it's again, it's such a difficult decision.
There are guidelines. New York State put out a massive, thoughtful set in 2015. The Italians have drafted a set based on their current experience, but every hospital follows essentially its own guidelines.
We're trying to save the greatest number of lives possible. So in some cases, these guidelines would really shift radically the way we work and put both patients and doctors and families in the terrible position of saying, we can't do what you would want.
Dr. Tia Powell is Director of Bioethics at Montefiore Medical Center in New York.
And the basic goal is to divide people into three large categories. One, the lucky group. Maybe you'll have a very mild case. You might feel miserable, but you're not in danger. The group that you're looking for in a hospital is the group that is very sick and that actually may die without critical care resources. But if we can get them those resources, they have a good chance of pulling through. And then the third group is the most unlucky. That's people with a terrible prognosis, people for whom, even with critical care resources, the chance of surviving is terrible.
I'm sure it's not a term that you will happily use, but we're talking about rationing.
It's a form of rationing, yeah. And I agree, everybody tries to avoid that word, but I would actually like people to understand what may be coming.
What we fear will happen, what is most likely to happen, is that persons who are poor, persons who are racial ethnic minorities, are less likely to get ventilators than those who are wealthy and well-connected.
David Williams is a professor at the Harvard School of Public Health.
And what makes it even more challenging is that the disadvantaged groups we have just talked about, they are the ones who begin this process being more vulnerable because they have earlier onset of disease, more likely to face chronic, ongoing stressors in multiple domains of their lives. So we're looking at those most in need being most likely to be disadvantaged.
We have to keep trying and doing things. So is it likely that people will die from lack of access to ventilators? Probably. Does that mean as an individual patient, they're likely to die? No, because we're not going to quit trying.
So I understand why you're fighting me on this. You don't want to let anybody believe that the medical community is just going to give up. And I'm not suggesting that you will. But I am suggesting in the strongest terms that we don't have adequate supplies to meet the likely demand. You don't think that's an unfair statement, do you?
Given my knowledge of the situation, that's not an unfair statement. But I'm not a supply guy, I'm a doctor.
Do you think the public is adequately informed about...
No, I'm not. I don't think that the healthcare community is adequately informed. And I think, experts have been working on this, but now it is really a realistic possibility. And it's a realistic possibility not in a year, but soon. I never thought I would see this day. We're not quite there, but realistically, many, many health professionals are preparing to do just this.